It gives me great pleasure to welcome you all in our webinar this evening about the last advances in the treatment of heart failure and management of type 2 diabetes and cardiovascular disease, which will be discussed. It gives me also the pleasure to have two eminent speakers tonight with us, Dr. Khadija Hafid and Dr. Muhammad Al-Harari. Our speakers will be discussing the topic of heart failure in general and in the context of patients with type 2 diabetes, because as we all know, that heart failure is a clinical syndrome characterized by a reduced ability of the heart to pump out or to fill in with blood. And this has become a pandemic recently due to the advances in the and the improvement in the healthcare system, which resulted in prolonged life expectancy, and thus the appearance of heart failure more and more in patients. And as we all know, this has become an economic and clinical burden. And for that reason, we should have a better understanding of it and a better way of managing it. So tonight we will be discussing the management of the cardiovascular disease and including heart failure in patients with type 2 diabetes. And this will be presented to you by our first speaker, Dr. Khadija Hafid. Dr. Khadija is a consultant physician and a consultant diabetologist and head of the diabetes unit in Rashid Hospital. She's got a great experience in type 2 diabetes and type 1 diabetes as well in the management of patients. And I have known her over the year as an excellent diabetologist, and I'm sure that she will be presenting an excellent topic today. And welcome, Dr. Khadija.
Thank you so much for that kind introduction. I'm delighted to be joined by everybody this evening. And I'd like to take this opportunity first to thank the organizers for inviting me to be part of this important webinar. I'll just sort of start sharing my screen. So hopefully that works. Give me a thumbs up if you're able to see my screen. Okay, right. So my task is to really go over the management of cardiovascular disease, and I'll touch just a little bit on heart failure because the next speaker will be talking about that in more depth in patients with type 2 diabetes. And before I do that, here are my disclosures. And the objectives is really very simple. What I'm going to try and do is highlight the unmet needs for patients with type 2 diabetes in relation to cardiovascular disease by discussing the role of the cardiorenal metabolic systems, particularly in diabetes. And then I will look at the evolution of the international guidelines with respect to glucose-lowering drugs, and then explore this paradigm shift that has happened in the management of type 2 diabetes. So as we can see here, cardiovascular disease is the #1 cause of death in patients with type 2 diabetes. We know that during their lifetime, half of our patients with diabetes will diabetes increases for, look at the Kaplan-Meier curves for 3 populations. Here we've got the patients who have diabetes and are known to have atherothrombosis prior to having an ischemic event. And then the patients that have diabetes but no known ischemic event. We can see here that the patients that have diabetes and known atherothrombosis with no prior MI have a greater risk than the patients that have diabetes alone. And then we also recognize the fact that 60% of the initial cardiovascular disease in patients with diabetes is actually born out of the cardiorenal systems. So this residual risk in patients with type 2 diabetes is multifactorial. Part of it is the chronic kidney disease, and we also have the under-recognized complication of heart failure. Now, to understand why that is, we need to acknowledge the fact that the cardiorenal metabolic systems are interrelated. So the heart is really quite a metabolically demanding organ that is susceptible to changes in both volume and metabolism. On the other hand, the kidneys play a significant role in both glucose and volume homeostasis, and as we know, are important for blood pressure regulation as well. On the side of the metabolism, we have regulation of energy by the liver, the pancreas, and the adipocytes. And the health of these organs is really essential for the function of both the heart and the kidneys. So patients with type 2 diabetes are at an increased risk for cardiovascular disease and heart failure. In fact, heart failure is something that is really under-diagnosed and undertreated for most of the times. We know that patients with type 2 diabetes have a 2 to 5-fold increased risk of hospitalization for heart failure. And then we know that diabetes and hypertension is also the #1 leading cause for end-stage kidney disease worldwide. And the presence of chronic kidney disease increases the risk of mortality in patients with diabetes. So these three systems are really interrelated. How do we manage these complications then? The glycemic management has to be coupled by the use of cardiorenal protective glucose lowering agents with an emphasis on the management of weight and by addressing the cardiovascular risk factors. In fact, we know that that's important because if we only concentrate on glycemic management, as was shown in the Accord, advanced in the UK PDS, we are able to get only a modest benefit in terms of sorry about the interruption. So I was saying that with just concentrating on the glycemic control, we're not able to get any effect on the all-cause mortality. So now what about the management then? It has to include a multifactorial approach whereby we're addressing all the risk factors. So it's not just about managing glucose. The blood pressure is equally important. LDL cholesterol and the other lipid profiles and diet and lifestyle and smoking cessation are equally important. Now, because of lack of time, we won't be able to talk about all the risk factors, but we will concentrate mainly on glycemic management. Let's put that on point mode. So the STINO2 trial was an important trial that actually showed that multifactorial management is really important. It showed that if you were to address all these risk factors together, you're able to reduce mortality. As you can see here from the Kaplan-Meier curves, the patients that were in the intensive group were addressed simultaneously were in fact much lower mortality the patient's conventional. We've had this shift in the management of type 2 diabetes from mainly a glucose-centric approach of only lowering hemoglobin A1C to what we refer to now as a person-centric, where we're looking at the comorbidities and other risks for the patients, particularly the cardiorenal risk. And in fact, over the last few years, there's been a from the Cardiac Society and from the diabetes societies with regards to the management of type 2 diabetes and cardiovascular disease. In fact, Even the Emirates Diabetes Endocrine Society updated their guidelines in 2020 to address the fact that this the management of type 2 diabetes has to incorporate the cardiovascular disease risk factors. So in 2020, we centric approach, whereby patients who have either established atherosclerotic disease, heart failure, in addition to their lifestyle modification or metformin, we need to look at, we need to add a GLP-1 receptor agonist or an SGLT2 inhibitor, irrespective of what the hemoglobin A1C is like. If the patient does not have CKD or atherosclerotic cardiovascular disease or heart failure, then one can shift towards A1C-based therapy. So the guideline in 2022 looks like this, and I'll walk you through it. So if we're choosing medications for people with cardiovascular disease, the first thing that we need to look at is whether they've got established atherosclerotic cardiovascular disease or indicators of high risk. And if that is the case, then we need to select either a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven benefit. And if the A1C is still above target, then if your first choice was a GLP-1 receptor agonist, you add an SGLT2 and vice versa. What about if the patient has predominantly heart failure? In this case, the first choice should be an SGLT2 inhibitor with proven heart failure benefit. Likewise, if the patient has predominantly chronic kidney disease and they're already on ACE or ARBs, the preferable agent would be to use an SGLT2 inhibitor. So if we were to just sum up and summarize that part of the algorithm, if the patient's got atherosclerotic cardiovascular disease, so they've either had a stroke or a heart attack, choose a GLP-1 with proven cardiovascular benefit. On the other hand, if it's mainly CKD or heart failure, then an SGLT2 inhibitor is your first choice. Why this is so is because we've seen in clinical trials, and I'll show you some of those, is that the SGLT2 inhibitors have got both metabolic and cardiorenal benefits in terms of reducing MACE, cardiovascular death, and hospitalization for heart failure. Whereas the GLP-1 receptor agonists mainly have a reduction in adverse cardiovascular events and cardiovascular death. So we can see that these two agents have things that are in common, which allow them to mediate these cardiorenal benefits. They both reduce glucose, they both reduce weight and blood pressure, and they're known to reduce visceral fat and have a very low risk of hypoglycemia. But there's some specific effects that the SGLT2 inhibitors have, which allow them to exert these cardiorenal benefits. Primarily, they promote an osmotic diuresis and a natriuresis. They reduce the intraglomerular pressure and interstitial edema. They are known to increase erythropoiesis and have a beneficial effect in reducing albuminuria and preserving the EGFR. On the other hand, the GLP-1 receptor agonists mediate the cardiorenal benefits mainly through an antioxidative, anti-inflammatory, and anti-arteriosclerotic effect. So the SGLT2 inhibitors tend to give us a quicker response than do the GLP-1 receptor agonists. Here is a forest plot of the studies that have been conducted for both SGLT2 inhibitors and the GLP-1 receptor agonists. And as we can see, all the SGLT2 inhibitors have demonstrated a reduction in MACE, whereas GLP-1 receptor agonist. We see that within the classes, liraglutide, biglutide have a beneficial effect towards reduction in MACE. Then when we look at the hard kidney endpoints, we see that the SGLT2 inhibitors do better. All of them have shown to have a reduction in the hard kidney endpoints, whereas again, there's some sort of heterogeneity when it comes to the GLP-1 receptor agonist, except for liraglutide. And death, it's T2 inhibitor class, and liraglutide and semaglutide have demonstrated this reduction in cardiovascular death in patients with type 2 diabetes. Heart failure is one that is unique only to the SGLT2 inhibitors. So as you can see in the blue dots, all the SGLT2 inhibitors were able to reduce hospitalization for heart failure, but that's not something that we saw or with to be to inhibit. So if we summarily used in the management of type 2 diabetes, we can appreciate that for the SGLT2 inhibitors, they're the only agents that show a reduction in MACE, a reduction in cardiovascular death, hospitalization for heart failure, the hard kidney outcomes, albuminuria, and all-cause mortality. Of worsening of the EGFR, but this should not cause clinicians to panic, because usually there's a small dip that is followed up by a rise and then a sustained preservation of the EGFR. There might be an increased urination initially, because remember, the drugs act by promoting a diuresis. This is, however, a very transient effect and may only be a problem in elderly patients or patients that are on high-dose diuretics, whereby it may lead to volume depletion. But this is not something that we worry about in the vast majority of the patients. Mycotic genital infections and urinary tract infections can occur in those patients who do not have very good personal hygiene, and therefore we always educate our patients when we're starting these agents that they need to be quite meticulous with their personal hygiene to reduce the risk of these infections. DKA is a possibility, only in mainly in patients with type 1 diabetes, or in patients who have very high hemoglobin A1C levels, whereby they might be insulin deficient. And therefore, we usually recommend, if you're going to start an SGLT2 inhibitor in somebody who's got a hemoglobin A1C that's above 10%, they should be on an insulin as well. So now, how do we leverage the SGLT2 inhibitors so that we can have a shared approach and prevent our patients from slipping through the cracks? We need to have this shared responsibility where the diabetologists, the cardiologists, the internists, primary care physicians, and nephrologists are all focusing on the same thing. So it's not just the glucose control or just the blood pressure control, but looking at the big picture and addressing all the cardiovascular risk factors. Here I've shown you the pattern of prescription of patients that are on SGLT2 inhibitors, and we can see that the highest is for those patients that are on from the endocrinologist, and very few from internal medicine, family practice, and cardiology. In fact, when we look at, this was a study that was conducted in both the US and the UK, and whether we actually are adhering to the guidelines, we can see that there's a lot of clinical inertia. Less than 10% of these patients that had cardiovascular disease and needed to be on these cardioprotective agents were actually receiving them. And this clinical inertia stems from a number of factors. the personal experience of the clinician, insufficient opportunities for treatment evaluation, lack of interdisciplinary care, and sometimes just limited knowledge of evidence from the CVOT trials and the cardiorenal risk. So the American College of Cardiology came up with this manifesto to reduce and defeat clinical inertia. We need to advocate for the CVOT treatment pathways. We need to be a local voice for the local guidelines. We need to collaborate on education of both patients and physicians. We need to deliver interdisciplinary care, educate the insurance companies that these agents are really life-saving and therefore they should be reimbursed, and then facilitate patient empowerment for being on these drugs. So I will finish off with a patient vignette. This is a 65-year-old lady with type 2 diabetes. She's had a coronary event. She's obese. She's also got hyperlipidemia and hypertension, and presents for her evaluation. She doesn't have any symptoms at present, but she's got a BMI of 40. Her blood pressure is 144/86. Her lungs were clear to auscultation, but she's noted to have bilateral ankle edema. At present, her hemoglobin A1C is 7. She's got a normal EGFR, you can see there, of 72, and the medications are shown here on the right-hand side. And the question would be, how would we modify this lady's anti-glycemic agents so that we can improve her cardiovascular outcomes? So the one thing to remember is that we need to give her an agent that is cardioprotective. She's got signs of what might be heart failure. So we look at the proBNP, do her echo, and irrespective of what her ejection fraction is, an SGLT2 inhibitor would be indicated. And because she's got a BMI of 40, the use of a GLP-1 receptor agonist would also be appropriate. And so we asked, is the addition of a GLP-1 and an SGLT2 inhibitor an option? For this particular patient, it would, because it would target a number of pathways. So the combination would actually be good for helping her to reduce weight, to reduce the ischemic cardiovascular events, and it would also be renal protective. So we've seen that these agents have some sort of class-specific effects, but overall, they both improve the cardiovascular outcomes. So my key points for you to take away is that diabetes in of itself is a key risk factor for heart failure. There's a substantial proportion of individuals with type 2 diabetes who will develop structural heart abnormalities, even in the absence of hypertension or coronary arterial disease. The presence of structural heart abnormalities increases the risk of clinical heart failure. There are multiple potential mechanisms in type 2 diabetes that can lead to progression from one stage to the other. And once symptomatic heart failure ensures, in type 2 diabetes, prognosis becomes very guarded. So to summarize, therefore, dear colleagues, we know that the cardiorenal metabolic systems are interrelated. Dysfunction in one organ system can actually cause problems in the other organs. Type 2 diabetes, cardiovascular disease, heart failure, and chronic kidney disease are all interrelated, and the presence of type 2 diabetes is associated with both cardiac and renal disease progression. So we need to have a holistic approach to type 2 diabetes care in order to address the cardiovascular, renal, and metabolic aspects of the disease. And finally, we have guidelines and societies that recommend the use of these agents, and therefore we should try as much as we can to adopt these agents and defeat clinical inertia. With that, I'd like to thank you for your attention, and I will hand over back the mic to our chair. Thank you.
Thank you very much, Dr. Khadija, for this extensive and explicit lecture about heart failure with type 2 diabetes. And I would leave the questions and answers till after the next subject. The next subject will be presented by our second eminent speaker, Dr. Mohammed Al-Harari, who is a consultant cardiologist with special interest in heart failure in Tawam Hospital in Al Ain, in UAE. And Dr. Mohammed is going to talk to us about the latest updates in heart failure management. So welcome, Dr. Mohammed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's really a pleasure and honor for me to be here. Let me just see if I can move this away. Yeah. I'd like to thank the organizer for inviting me, and thanks Dr. Jamila for the kind introduction. My task tonight, ladies and gentlemen, is to give you a flavor of the latest updates in heart failure management. Don't think I can cover the whole thing in 30 minutes, but we'll see how we go. Let me just move the slides. Okay, so what I'll try to talk about, give you the new definition and classification of heart failure, the new revised stages of heart failure, the new American guidelines algorithm for the HFrEF management, and the place of a SGLT2 inhibitor, talk about EMBRA, reduce, and a little bit about DABA heart failure trials. We'll talk about how we should prescribe guideline direct medical therapy in HFrEF patient, and the issue or the concept of therapy according to patient profile in HFrEF management. I'll touch on a few other new things in the medical management of HFrEF. Then we'll move on and talk about the new HFmREF and HFpEF recommendation in the new American guidelines, highlighting the trial of EMBRA, BREZEF, and a little bit about the DELIVER trial. And then we'll move on to the initiation of guideline direct medical therapy during hospitalization with acute decompensated heart failure, going over the Pioneer and the Impulse trials. I don't think I'll be able to cover management of acute decompensated heart failure, device therapy, valvular heart disease in heart failure, or advanced heart failure. So before I start, I just need to remind you and myself of class of recommendation. If you see in any guidelines, anything highlighted green, that means you should do, you must do. It's obligatory, unless there is a good reason not to. If you see it, it's class 1. If you see it colored in yellow, that you should consider it. It's class 2A recommendation. If it's in orange, you may consider it. But if it is in red, you should not do it. It's class 3. So in March of last year, the Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, and the Japanese Heart Failure Society met together and proposed a new definition of heart failure and a revision of the classification revision of the stages of heart failure, which has been since adopted and incorporated in the new American guidelines of heart failure, published May of this year. So the definition of heart failure remains as a syndrome of symptoms and or signs of heart failure with underlying structural or functional abnormality of the heart. But on top of that, you need one of two, either an elevated natriuretic peptide and or clear objective evidence of pulmonary or systemic congestion. As far as the classification of heart failure based on the ejection fraction, you probably know already. It is HFrEF if ejection fraction less than 40%, HFpEF if ejection fraction equal to or more than 50%. In between, it's called HFmREF, which is mildly reduced, not mid-range as used to be called. However, the new class based on ejection fraction is called HFmREF, which is heart failure with the improved ejection fraction. And this is for people who had ejection fraction lower than 40%, but now it's more. And why are we making this class? Because these people should be treated as HFrEF, not as mildly reduced or HFpEF. And we'll come to that later on. Now, the stage of heart failure has been revised. Why? To emphasize on the importance of presence or absence of symptoms, number one, and also highlight the progressive nature of heart failure. So class A now is called patient at risk of heart failure. This is all your diabetic, hypertensive, the obese, family history, exposure to toxic medications. They're all stage A already at risk of heart failure. Stage B, this is the pre-heart failure. Those people do have abnormal heart, either structural or functional, but they've never had symptoms or signs of heart failure. Then moving on then you go to the proper stage C heart failure. These patients did either now or did in the past have symptoms and or signs of heart failure. And these are either now have resistant heart failure or heart failure in remission. Okay. Now those patients tend to, and a lot of them do, progress to advanced heart failure. And some patients can present directly with advanced heart failure, where they're struggling despite maximum treatment. They could be in inotropes. They're usually referred to an advanced center for consideration of mechanical support, transplant, or worst scenario, palliative care. These patients, if they improve, they can go back to stage C, but you don't go from stage C to stage B or A, okay? And what we should not do anymore, should not label our patient as stable heart failure. This term should not be used because it really gives you as a physician and the patient a false comfort feeling that everything under control, which never is. So the term should not be used. Now for stage A and B, what the algorithm tells us. So it tells us, do you really treat the risk factors? And with Khadija, elegantly highlighting the importance of controlling risk factors. So if you're hypertensive, you should be treated. If you're diabetic, you should control your diabetes, and you have risk factor, you should go, as Dr. Khadija told you, should go into a SGLT2 inhibitor, and this is green, should do, must do. If you have underlying coronary disease, you have to have revascularization. If you are exposed to cardiotoxic medication in oncology, you have to be under multidisciplinary care team, including cardiologists. If you have a strong family history of idiopathic cardiomyopathy, you need gene studies. And if you are at risk of heart failure, it's class 2A recommendation to do natriuretic peptide. So if you got somebody in front of you, you're worried that they are a high risk, do NT-proBNP B. This is really now class 2A recommendation. Now, if you are stage B, which is the pre-heart failure, you already have abnormal heart. Therefore, you should go on guideline-directed medical therapy. So what's the algorithm to screen for and diagnose heart failure as per the guidelines, which is similar to the European Society of Cardiology of last year and the American guidelines this year? If you have somebody with suspected heart failure, you have to take good history examination, do the baseline lab, X-ray, ECG, and do NT-proBNP. If they are high, or if you are still very high suspicion of heart failure, do an echocardiogram. And if that's abnormal, then you get a diagnosis of heart failure. You just need to phenotype it to is HFrEF or HFmrEF, look for etiology and treat. Now, as far as the management of HFrEF, we've been fortunate. Over the last 2-3 decades, we had so many trials that showed us mortality and morbidity benefit in these patients, starting with the ACE inhibitors in the 1980s, the beta blocker, but specifically, only, not specifically, carvedilol, bisoprolol, and metoprolol succinate, and MRAs, spironolactone, and eplerenone. And we had a long gap until 2015 when we had the very important landmark trial of paradigm trial that showed us that we have a new agent called sacubitril/valsartan, which actually is superior to a very well-established agent, which is an ACE inhibitor, giving us an added 20% reduction in cardiovascular outcome, which I won't go into the details. So by 2016-17, the European and American guidelines took all this information together and produced their guidelines incorporating all these medications. But the problem that they put it in a sequential approach, i.e. start with one agent, maybe 2 agents, increase the dose, see them in 2 months' time, add another one, see how they're doing, consider the device. It takes 2-3 years to achieve what you need to achieve from wherever within 1 or 2 months. And by that time, a lot of patients would have been dropped dead. And we'll explain that in a minute. So what happened since those guidelines came up? We had a gap from 2015, no really major trial until 2020, when we had the EMBRA reduce. Now, out of nowhere, diabetic medications have been studied to treat heart failure. So the EMBRA reduce is a large trial, nearly 4,000 patients of HFrEF, NIHA class 2 to 4, diabetic and non-diabetic, randomized to empagliflozin or placebo, followed up for a median of 16 months and looking for cardiovascular outcome. And I need to point out to you that these patients, the study recruited patients with CKD with the eGFR down to 20. down to 20. It's against, the guidelines, renal guidelines, but for heart failure, up to 20 you can give. And the study was very positive. It meets all its primary and secondary endpoints with 25% relative risk reduction of the composite endpoint of cardiovascular death or heart failure hospitalization with a number to treat only 19. And the effect was seen in the first 12 days. To do not delay, start early. You don't have time, really. You just start early, the benefits seen quickly. You will get 30% reduction in a heart failure hospitalization by giving them empagliflozin. And you slow the progression of the decline of the eGFR with EMBA compared to placebo. And the study showed that you have 50% relative risk reduction of progressing to end-stage kidney disease or sustain a profound decrease in GFR. You improve your quality of life. It doesn't matter whether you're diabetic or not diabetic. It doesn't matter whether you're taking ARNI or not taking ARNI. This completely independent effect. And around the same time, we had the DABA heart failure trial, which looked into dapagliflozin versus placebo in a very similar design to this trial to the EMBRA reduced, and showed similar benefit, 26% risk reduction in composite outcome. What we learned as well around that time or later on is really the importance of combination of these medications. So giving somebody with HFrEF an ACE inhibitor, beta blocker, yes, they do better, but not as good as if you give them the whole thing, the ARNI, the beta blocker, the MRA. So they have much more significant reduction in cardiovascular mortality and heart failure hospitalization. And knowing that the 2 years mortality for HFrEF is 35%, if you give all the agent and if you add SGLT2 inhibitor on top, you reduce that to 9.5% from 35%. Significant, isn't it? But the combination, not one on its own. And what also we know that deferring starting medication is bad. So if this is before the SGLT2 inhibitors, so if you give the patient the other triple therapy of 3 pillars, 1 year mortality survival is 90%. But if you decided to say, okay, let's give the spironolactone, the aldosterone antagonist, maybe in 2 months' time, by deferring that, you reduce their survival. If you defer the beta blocker, you reduce it further. So by deferring it, you're going to give it. But you say, well, I'm just going to give him some time. I'll see him 3 months' time. A lot of patients will die, and it is your fault. So the new guidelines or algorithm still have a stepwise approach, but what's step one? Step one, you give all the 4 pillars together, all of them. The MRA, the beta blocker, the SGLT2 inhibitors, and the ACE, ARNI, or ARB as stage 1. All together as soon as it is safe to do so. That's what step 1 is. And SGLT2 inhibitors now out of nowhere become class 1A recommendation. And the ARNI, according to the American, is class 1 recommendation in preference to ACE inhibitors, which should be used only for patients who cannot afford or cannot tolerate ACE inhibitors. Now, what's step 2 in this new algorithm? Step 2 is that the importance to titrate the dose of the medication to the target. It's class 1 recommendation. You cannot just give them a bisoprolol of 2.5 and just leave them on that forever. You need to titrate the dose of that. Same for ARNI. SGLT2 inhibitors do not require titration, fortunately. And it's class 2A recommendation that you should do this quickly, like every 1 to 2 weeks. You cannot start medication, don't start an admission and start it 2 months later and see them 3 months later. You need to do this quickly for the reason we explained. Now, part of step 2 is the highlighting this HFmBEF. So patient who ejection fraction was poor, down in HFrEF and improved should be treated with all guideline-directed therapy. Why? Because if you stop it, 44% of them will relapse, as been shown in this TREAD heart failure trial. And it's class 1 recommendation to do this. You should do it. So then how do we start these things? What's this patient profile thing? And, the important thing that you should not do it in this old-fashioned sequential way of giving one drug and wait and wait and wait. Your aim to start all the 4 pillars as soon as possible, day 1 if you can, and titrate quickly. As I said, GLP-2 inhibitors does not require titration. The MRA, very little titration. The titration mainly for RNA and beta blockers. Now, again, to address this issue, the Heart Failure Association of the European Society of Cardiology produced a document in May of last year looking into this issue. And basically what it says that you put this like all your 4 pillars here in the middle black circle, the MRA, CL2 inhibitors, RNA, ACE, and MRA, and CL2 inhibitors, and you put your patient will be fitting in one of those 12 or 14 profiles around. So if your patient is fine, normal blood pressure, normal kidney, you should start all the 4 of them. And if they are, and starting them or continuing them is written in black in the middle here. And if they need, you can add in blue very quiet hydralazine and nitrate, which maybe we'll go over later on. If your patient has a potassium for 5.5, then you have to ease or stop the MRI, the ACE and R. If your patient has a low blood pressure or low heart rate, you may ease on the beta blocker in red here, or the ACE or R, and so on and so forth. But what you notice in all these profiles, that a lot of them you probably have come across, that the SGLT2 inhibitor remains in black, because you have very little reason to stop or not start a SGLT2 inhibitor. And this is the consensus of the document, that to maintain SGLT2 inhibitors across all phenotypes of patients. Now, what's step 3? Step 3, you look at other things. So if they are Black American, they're struggling, you can add hydralazine and isobarbitol. If they are ejection fraction is less than 35%, and they've been on medication at least for 3 months and they didn't improve, consider ICD. And if they have a left bundle branch block with wide QRS, consider CRT. I must mention the issue of iron deficiency, which is an important thing, because 80% of your patients admitted with acute decompensated heart failure have iron deficiency, and 55% of the chronic. Iron deficiency does not equal or equate anemia. So you can have hemoglobin up to 15 and you be iron deficient. And this is defined as per the heart failure guidelines by having a serum ferritin less than 100, or if it is between 100 and 300, but you have a transferrin saturation of less than 20%, these are people are iron deficient, and they will benefit from giving what? IV carboxymaltose, not the iron tablet, not any other form of IV iron. It has to be carboxymaltose. And this has been shown by the AFFIRM acute heart failure trial. And it's class 1 recommendation to screen for and treat iron deficiency, both in acute setting and the chronic setting. Now, step 4 is to consider other medication. If your patient, you give them all the medication and they're still struggling, all the 4 pillars. The ivabradine, if the heart rate is more than 70 despite maximum tolerated beta blockers, if they are in science driven. For risk squad, I need to go over it very quickly. There's a new agent acting in a completely different pathway called nitric oxide, cyclic GMB, the name run, I lost the thing. But anyway, it's a completely new pathway, and it's been used in people with worsening heart failure, requiring recent admission or IV diuretic in the Victoria trial, with significant reduction in mortality and morbidity, and it's now a new class 2B recommendation. Digoxin remains as before class 2B recommendation. Polyunsaturated fatty acid, again, there is an old thing from the GSIS heart failure trial. Very few people, I think, use it. But the other new one is the use of potassium binder. Now, this is very important. Why? Because you've probably seen it. A lot of patients develop hyperkalemia, and they end with what? Stopping their RAS inhibitors, stopping their RNA, stopping their ARB, stopping their ACE, stopping their spironolactone. And they say, well, we cannot tolerate it because of hyperkalemia. And what's the problem with that? You deny them life-saving medications. These potassium chelating agents, the bacteremore and the SZC, what they do, they stop the absorption of potassium from your gullet, maintaining your potassium, allows you to give this very important life-saving medications, as been demonstrated in the recently published Diamond trial using bacteremore that allows you to give this life-saving medication. So what about this HFmREF and HFpEF? Now, you need to remember that the incidence or the prevalence of HFpEF is going up all the time, and it is now more than 50% of all heart failure. And the mortality as bad as the HFrEF. It's not a benign condition. Having good LV on echo is actually quote unquote, is not a benign condition if you have heart failure. So unfortunately, over the last 2-3 decades, again, a lot of trials fail to give us convincing mortality and morbidity benefits. ACE inhibitors do not work. ARB, in the form of candesartan, as in the CHARM preserve trial, was a very good trial, and it did not meet the primary endpoint of the composite heart failure and cardiovascular death, but it did show as a secondary endpoint reduction in heart failure hospitalization, and it's been for a while class 2B recommendation in HFpEF. Similar thing with the spironolactone, the TOPCAT trial failed to meet its primary endpoint, but did show a secondary endpoint reduction in heart failure hospitalization. Now, more recently, in 2019, we had the Paragon trial. It's a huge trial, again, looking at the use of sacubitril/valsartan, not against placebo, against an active comparator, which we know sort of work, and ARB, valsartan. Unfortunately, the trial overall did not meet its primary endpoint of reduction of the composite endpoint of heart failure, hospitalization, cardiovascular death. But when they look at people with ejection fraction of up to 57%, they do benefit. Female, which constitute more than 50% of the trial population, benefit regardless of their ejection fraction. They do better with sacubitril/valsartan versus valsartan alone. But the real breakthrough occurred really in August last year when we have the result of the EMBRA preserve trial, which looked into the use of empagliflozin in patients with HFmrEF and HFrEF, so anyone with ejection fraction more than 40%. Huge trial, nearly 6,000 patients, diabetic and non-diabetic, and a long follow-up, 26 months, and looking at the cardiovascular outcome. 2/3 of patients actually were HFpEF, and the trial met all its primary and secondary endpoint, with primary endpoint 20% reduction, 21% red risk reduction if the composite heart failure and cardiovascular death, number to treat 31. Again, look at the curves. They separate very early to start your treatment early. Thank you. Yeah, I think you got the message now. And it showed 27% reduction in the heart failure hospitalization. And again, shows significant reduction in the slowness or reduction in the slope or reduction of the eGFR. Again, better quality of life, regardless if you're male or female, regardless if you're diabetic or not diabetic, regardless of the underlying medical therapy, across all ejection fraction. What else do you want? The new, they missed the European cardiology guidelines last year, but the new American guidelines has put, following the EMBRA preserve, SGLT2 inhibitor as class 2A. This is the first time we have a class 2A recommendation for HFpEF. And the other, the RNA, MRA, and RB remains class 2B. And also for HFmrEF, SGLT2 inhibitors took, because of the EMBRA preserved, took class 2A recommendation now. More recently, in the August this year, in the European Society of Cardiology, we had the DELIVER trial was presented. DELIVER trial basically was a similar design to the EMBRA preserve, using dapagliflozin in HFmrEF and HFrEF patient, and again showed significant reduction in the primary endpoint of composite cardiovascular death or worsening heart failure, which should now make a SGLT2 inhibitor as class 1 recommendation, not class 2A. Because you got 2 large randomized trials showing benefit. So what about patients get admitted to hospital with acute decompensated heart failure? Is it safe and effective to start guideline-directed therapy? I need to remind you, we talked a lot about how important to start medication early, combine, titrate quickly, but it's also important to start inpatient because the patient will get admitted have the highest mortality. And after discharge, 10% die within 1 month and 30% get readmitted. So you cannot really afford to say, I want to start them when they come to the clinic. You need to start this medication early. And we know, even from previous evidence, that if you start medication during admission, say, for example, here, MRA, during hospitalization, at 1 year, 85.5% are still on MRA. But those who decided to start spironolactone in clinic, only 22% at 1 year will have it. Similar thing with ACE inhibitor. So start early for better protection and more assurance that the patient will be on it in a year's time. So the first drug I mentioned regarding starting medication during hospitalization of guideline-directed medical therapy is the Pioneer trial using sacubitril/valsartan in HFrEF patient, comparing it with active comparator, enalapril, and it showed it is safe, but also effective, significant reduction in death, rehospitalization, in T-BROMB, name it. And number to treat only 13. But more recently, we have the Impulse trial. Now, what the Impulse trial did, really, randomized patient who admitted with acute decompensated heart failure within 4 days of admission to either empagliflozin or placebo as soon as they get stabilized, which we'll talk about that in a minute, and follow them for 3 months. Even in 3 months, which I'll show you that it did work. And they look at this composite of this endpoint, and I will talk about how they did this win ratio thing in a minute. And what stabilization? It doesn't really need much. Most of our patients that we see next day, they're stable. So they have a decent blood pressure of more than 100, and they are not needing more IV diuretic, and they are not on IV vasodilator or inotropes. If that's applied to them, you start with SGLT2 inhibitors. Again, a third of the patients were HFrEF or HFpEF, the others were HFrEF, so it's combination. Third of the patients were de novo, means they're new heart failures. The 2/3 were acute and chronic, and they were in a good baseline background direct medical therapy. And what the study was, how they really assessed, they look at 4 criteria in each patient: death, number of heart failure hospitalization, time to first heart failure hospitalization, and their quality of life questionnaire. And look at each patient in the treatment group, the empagliflozin group, and compare each patient in the treatment group with every patient in the placebo group. And they look out that patient compared to that patient, and look at this criteria, which is better, which did better compared to the other one, using all these 4 criteria. And then what they did the win ratio, which is a new way of assessing significance or benefit of medication or intervention, whatever. So the win ratio is the total number of wins in the EMPA group divided by total number of wins in the placebo group. And basically, the trial meets all primary and secondary endpoints and show that patients on the empagliflozin were 36% more likely to experience clinical benefit. And they're less likely to die and less likely to be admitted with heart failure. And it doesn't matter whether they are de novo or acute and chronic heart failure. It worked whether they are diabetic or non-diabetic. It works whether you have a HFrEF or HFmBEF or whatever. It works all across. It has very similar safety profile to placebo. And now it's class 1. Okay, class 1 means what? You must start guideline direct medical therapy for patients admitted with acute decompensated heart failure, HFrEF. Now, in the middle of all that, you probably noticed that the empagliflozin is the first drug to show clinical benefit across patient journey, across the entire ejection fraction. Entire ejection fraction means HFpEF, HFmREF, HFpEF. Entire journey means even at risk, when we talk about diabetic, patient who get admitted, patient get to see in the community, they all benefit from being on empagliflozin. So in summary, ladies and gentlemen, and take-home messages, I think we did highlight the importance of early detection and diagnosis of heart failure, including patient class stage A and B. We talked about the importance of early initiation for as many of the 4 pillars therapy as possible, as safe to do so. Easy, early titration, early start, quick titration. Empagliflozin is effective and safe when given to patients admitted with acute decompensated heart failure, as we demonstrated from the Impulse trial. It is now class 1 recommendation to start guideline direct medical therapy during hospitalization. Empagliflozin is a single dose medication, and also same for diabetes, to be honest, and does not require titration, does not affect the electrolytes or blood pressure, can be given to CKD patient up to eGFR of 20. It is the first and the only therapy to improve cardiorenal outcome for full spectrum of heart failure patients, regardless of ejection fraction. And thank you.
Thank you very much, Dr. Mohammed, for your talk. And I believe that you have covered everything in it. And For the sake of time, we have few questions. We'll take few questions. I mean, a break just for answering few questions, and then we'll proceed with our third topic. The first question we have is asking about the mechanism of SGL2 in HFpEF.
Right. For me, to be honest, this is all speculation, all theoretical things. There is what we know. Some people use it's just a diuretic. It's not just a diuretic. It has really a lot, potential effect on the endothelium, in the RAS pathway. For me, what it matters, it does show it works. So when you use it, works. Regardless of your blood sugar, we show this works in diabetic and even non-diabetic. So it's not just diuresis with the sugar. So I think the mechanism, if you look at it, you'll find lots, slides of 200 mechanisms being thought of, but I don't think anybody has a clue. What we know, it actually even improve remodeling. So when you use it, your filling pressure for the heart improve, your left atrial size decrease. So it does have a direct effect on the heart. How is the mechanism? I think, is it just renal, heart, endothelium, combination of these? I don't think anybody knows for sure.
Okay, thank you,
Probably
Doctor.
I could just add to that about the mechanisms. There's an important concept about the ketogenesis as well. We know that the SGLT2 inhibitors do, and we think that these keto acids might be important for the contractility and the metabolism in the myocardium. And in addition to what Dr. Mohammed has already mentioned, it is possible that this aspect and the erythropoiesis is also probably one of the proposed mechanisms that help patients that are in HFpEF. We know that if it's HFrEF, it's mainly the hemodynamic effects, but for HFpEF, it's more towards the structural elements within the heart and the more efficient use of these sort of keto acids. So carry on.
Okay, so I think also in that talk it has answered another question which said that can we use SGL2 in for HFrEF regardless of the blood sugar levels?
Yeah, we said it's both diabetic or non-diabetic. So 50% actually were non-diabetic. So it's not just glucosuria.
Okay, and there is a question here for Dr. Khadija. If there is any role of combining SGLT2 inhibitor and GLP-1 agonist in heart failure in diabetic patients.
All right, that's a very good question. Thank you for the person who's asked it. And in fact, because we have not had trials that show that the combination will increase your cardiovascular protection. We just have the individual trials for SGLT2 inhibitors and for the GLP-1 receptor agonists. But we often use this combination in clinical practice for two reasons. One, we're able to, because we know that type 2 diabetes has a number of pathophysiological defects, and therefore you're able to hit and address these multiple defects with the two agents. So the SGLT2 inhibitors, as I showed you, would reduce glucose, they do have a reduction in the weight, a reduction in the blood pressure, and have a very low risk of hypoglycemia. So combine them with a GLP-1 receptor agonist, you get also further metabolic reductions. You've got further A1C reduction, which is good, for our patients, not just in terms of protection for the heart and the kidneys, but also for the microvascular complications as well. So the two agents used together are very important for glycemic control and for getting the individual benefits of both the cardiac effects and on the renal and the renal effects as well. So yes, it is Recommended to use, as I showed you on the guideline, if you start off with an SGLT2 inhibitor and the patient still hasn't achieved their glycemic targets, you may add on the GLP-1 receptor agonist and vice versa.
Okay, there is another question here for you, Dr. Khadija, which says, in the clinical vignette that you presented, why wasn't GLP-1 started rather than the SGLT2, especially that the patient had the MACE and both, both showed effectiveness in MACE?
So then the case that I presented, I highlighted that, this patient was not on guideline directed therapies. She was an obese patient that had evidence already of coronary artery disease. She had this myocardial infarction, and she had other, cardiovascular risk factors. She had dyslipidemia and hypertension. And therefore, she is a candidate for the cardioprotective glucose-lowering agents in the form of either an SGLT2 inhibitor or a GLP-1. But why I brought this case is to highlight the fact that in this particular patient, probably the two agents might be necessary, because you saw that her BMI was 40. You're unlikely to just address her weight with the SGLT2 inhibitor, although her HbA1c was 7%. So we're not just targeting the glycemia. Remember when I showed you on the algorithm, irrespective of what the patient's hemoglobin A1c is, you're trying to address the other factors as well. And in fact, in 2022, the ADA ESC consensus statement has actually emphasized weight as an important parameter in the management of type 2 diabetes, because it also impacts the outcomes in terms of the kidneys and it, in terms of heart failure as well. So that is why I brought in this this specific case, just to highlight that the two agents may be started together or sequentially in order to improve the patient's outcome.
Okay, thank you, Dr. Khadija. There is another question here which says, is there a certain cutoff of the GFR where you should stop SGLT inhibitors after starting them?
Right, so that's also a very good question, because as Dr. Mohammed had shown that, we know that there's usually a certain drop, an initial decline in the eGFR, and this causes a lot of panic. And then physicians get very edgy and they think, oh no, we're going to cause acute kidney injury, and they stop the drugs. That's not really the right approach. One should actually persevere, because eventually that eGFR is going to improve. And in fact, it's going to make, the fact that the patient is on the agents is going to increase and preserve the kidneys. Now, the only situations where you would want really to stop the medication is if the patient has come in with another illness, they've come in with an acute diarrheal illness, they've come in with a urinary tract infection, they've come in with a pneumonia, for instance, and you know that disease has caused an acute kidney injury. And if the patient was on an SGLT2 inhibitor, transiently you would have to stop it. Yes, during hospitalization, you would have to stop, allow for the kidney to recover because of that underlying condition, and then you can restart the agents later on. But now we have convincing data from the EMPA kidney and from DAPA-CKD and from the Credence trial that these agents can be used down to eGFR of 15. So they're safe agents, and they're, the nephrologists are now also adopting them as renal protective drugs, even in patients who do not have diabetes.
Okay, thank you.
Excellent. I agree 100%. Do not stop it, please. Even if just eGFR go below 20, do not stop it. And start it as low as you can. Start up to eGFR of 20, but once you start even good dips, don't stop. Just wait.
Okay. There is one question from an attendee here, wondering why ARBs are downgraded now. To start with ACE inhibitors or ARNI. I mean, what's the role, or where is the position of ARBs in the treatment of heart failure?
Okay, there's a slight discrepancy between the European Society of Cardiology and the American guidelines. So for the European guidelines, really still ACE inhibitors remains the #1 to use, and use both ARB and ARNI when ACE inhibitors cannot be tolerated or not working, whatever. And the European just dropped it, still class 1, but class 1B. So just dropped it a little bit, but still used as a replacement. What we always do, we don't start with R for HFrEF. We start with ACE inhibitors, even in the past, and then if it doesn't work, we use R. But now we have data from the paradigm that actually ARNI are better. So ARNI are better than ACE, but the Europeans still use it as a replacement, while the American say ARNI are first line, and ACE inhibitor to be used as only if ARNI cannot be afforded for whatever reason. So you still use R, but I would never use them as the first line. Only if you cannot afford ARNI or whatever, for cost or whatever, and if ACE inhibitors are not tolerated because of cough or whatever reason, then you can use R. They're still really to be on third line from this group.
Okay. We'll see. There is also another question here, says, what's the indication of furosemide in heart failure in the recent guidelines?
Furosemide. Okay, furosemide really, you look at it, actually class 1 recommendation. So class 1 recommendation, decongestion should be always your aim, whether it's HFrEF or HFpEF. So you have to take the fluid off. So, but as soon as your patient, so if you're volemic, so you reduce them and taper them and stop them. So class 1, but as needed, because no mortality benefit, but there's also symptomatic benefits. So decongestion, always the aim. Again, regardless of the kidney function, if the kidney function gets worse, you have the patient in front of you is really fluid overloaded. You have to diurese them. You have to get there. So they are in the guidelines. So it's very first line, both in the acute setting and the chronic setting.
Yeah. Let's see if we have any other questions that we can address. Okay, I think we'll stop the questions here and probably move to the next subject, which is the highlights of renal data with SGLT2I presented by Dr. Sarina Othman, Senior Medical Science Liaison, Heart Failure and Metabolism, Gulf, Iran and Pakistan.
Thank you very much, Dr. Jamila. And again, thank you very much on behalf of Boehringer Ingelheim for granting us this opportunity. And I would like again to thank Drs. Harari and Dr. Khadija for their very inspiring talk. Okay, so my name is Sarina Othman. I'm the Senior Medical Science Liaison for Heart Failure and Metabolism in Boehringer Ingelheim for the Gulf, Iran, and Pakistan cluster. And my short presentation will be mainly looking at the latest renal updates with SGLT2 inhibitors and some highlights from the upcoming EMPA kidney. So as you all know that several trials have been conducted looking in depth into the patients with chronic kidney disease, regardless if those patients had type 2 diabetes at baseline or not. And when we talk about SGLT2 inhibitors in particular, mainly dapagliflozin and canagliflozin in the respective trials, DAPA-CKD and Credence trials, those two SGLT2 inhibitors have demonstrated cardiovascular and kidney outcomes in patients with chronic kidney disease or for diabetic kidney disease. And this was mainly represented in reductions in the composite of kidney or cardiovascular outcome, composite kidney outcome, cardiovascular mortality or hospitalization for heart failure, or and all-cause mortality, mainly for dapagliflozin achieving its statistical significance. Now, when we look into the patients that were included in both DAPA-CKD and the Credence trial, we can mainly see that those trials mainly looked at patients with overt albuminuria, meaning patients with urine albumin creatinine ratio more than 200 milligrams per grams. So the Credence population were mainly patients with diabetic kidney disease and eGFR ranging between 30 to 90 milliliter per minute and a urine albumin creatinine ratio of above 300 milligrams per gram. So all the patients that were included in the Credence population were patients with type 2 diabetes at baseline. Whereas DAPA-CKD included patients with and without diabetes. So those patients had diabetic kidney disease and chronic kidney disease, and an eGFR ranging between 25 to 75 milliliter per minute, and a urine albumin creatinine ratio ranging between 200 to 5,000 milligrams per gram. So the Credence trial mainly looked at patients that were termed as high risk and very high risk, whereas the DAPA-CKD mainly looked at the patients ranging between moderately increased risk, high risk, and very high risk. However, we still have an unmet need in those CKD population, and those are the patients who either do not have albuminuria at baseline, and those population constitute up to 1/3 of the total CKD population. And as well, it has also been shown that patients who have a low eGFR, at baseline with no or mildly or even moderately increased albuminuria are prone to a risk of progression in their GFR, even if they had type 2 diabetes at baseline or not. Meaning for patients with GFR ranging between 15 to 29 with no albuminuria or mildly or moderately increased albuminuria, they are expected to have an eGFR decline ranging between 4 to 7%, irrespective of their type 2 diabetes status. In addition, if we look at the current treatments that have shown to have renal benefits, those treatments did not show solid benefits in patients who had CKD but had low grade of proteinuria. And here we are mainly looking at the treatments mainly in the RAS inhibition pathway. So those do not slow down the kidney function decline in patients with chronic kidney disease and low-grade proteinuria. Effectively, the EMPA-Kidney was designed to look at those patient population in particular. So EMPA-Kidney is a multinational randomized double-blind placebo-controlled phase 3 trial, mainly looking at patients with chronic kidney disease with and without diabetes. The EMPA-Kidney was terminated earlier than its original timeline in March due to the benefits that were achieved by empagliflozin and the achieving the events early on. And EMPA-Kidney is expected to be presented in the upcoming American Society of Nephrology in November. In a brief, EMPA-Kidney randomized around 6,000 patients into the EMPA 10 milligram cohort on top of standard of care versus placebo. The average duration of the trial is expected to be ranging between 30 to 48 months, in addition to a 1-month follow-up visit afterwards. So who were the patients that were recruited in the trial? So there were adults with an evidence of chronic kidney disease identified as an eGFR ranging between 20 to 40 milliliter per minute, or an eGFR ranging between 45 to 90 milliliter per minute with a urine albumin creatinine ratio of 200 milligrams per grams and above, and on a treatment of RAS inhibition, either ACE or ARBs. Mainly the exclusion criteria were type 1 diabetic patients and patients with polycystic kidney disease. So now, putting the three trials in context, EMPA-Kidney is now the first trial to look at patients with or without diabetic kidney disease, eGFR ranging between 20 to 45, or eGFR ranging between 45 to 90 milliliter per minute, and urine albumin creatinine ratio of 200 milligrams per grams and above, studying a broader range of a population with chronic kidney disease. So the primary endpoint was a composite of cardiorenal outcome, mainly looking into cardiovascular mortality and kidney disease progression, in addition to key secondary endpoints looking at hospitalization for heart failure or cardiovascular mortality, all-cause hospitalization, and all-cause mortality, in addition to kidney disease endpoints defined as clinical outcomes as end-stage kidney disease, defined as initiation of chronic dialysis or kidney transplant or renal death, eGFR-based outcomes, mainly looking at kidney function loss, defined as either sustained eGFR decline of 40% and above, or a sustained eGFR decline of a minimum of 10 milliliter and below. And as we mentioned, that the trial is anticipated to be presented in the upcoming American Society of Nephrology Congress in November. So as a summary, chronic kidney disease with low eGFR and no or mildly increased albuminuria constitute up to 1/3 of the total CKD population. CKD patients with low eGFR with no or mildly increased albuminuria have a huge unmet need, and the therapeutic options that are currently available are quite limited, as the RAS inhibition has not demonstrated to slow kidney function decline in those patient population in particular. And now EMPA-Kidney is designed to include a broader patient population with chronic kidney disease, whether those patients had albuminuria or not at the baseline. And in contrast to other trial, EMPA-Kidney also includes CKD patients with low eGFR and no or mildly to moderately elevated albuminuria, and those patients are known to have a relevant risk of chronic kidney disease progression with an annual eGFR decline of 4 to 7%. And by this, I end my presentation. Thank you very much.
Thank you very much, Rina, for the talk, which is explicit. And I think at this, we will come to conclude our meeting for tonight. It was a very fruitful, very elaborated talks with regards to the heart failure in diabetic type 2 diabetes patients and the role of the new generation of anti-diabetics in the management of heart failure. And I would like to thank everybody here, Dr. Khadija, Dr. Muhammad, and Dr. Serena. Thank you very much, three of you, for the presentations tonight. And I think we will conclude at this. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.